Shri Krishna, and good evening to everybody. Since this is a month of October, which is usually the month for the breast health awareness and the cancer also, so we thought let's just talk about this a little bit more. Many people know what the breast cancer is and what the breast health is, but this is a little bit details. And thanks to the good uh, panel we have, I'll just introduce them in a minute. So this is what we plan to do now. Breast cancer, these are some facts. This is not to scare you, but understand the reality. So these are facts, not the fear. So whatever we tell you, the numbers and everything is just a number, but we need to make sure that we don't become part of that number. So what we will discuss, maybe diagnosis, early diagnosis, then treatment options, both surgical, radiation, oncology, medical oncology, all those, and then prevention. And our goal is back to the normal where we started before the diagnosis and the treatment was done. So let me thank all our three great speakers we have today. Dr. Keene, Stacey Keene. She is FACR, that is the Faculty of College of Radiology, and she's practicing for 30 plus years in Maryland. She is a diagnostic radiologist, expert and dedicated work at the Advanced Radiology in Maryland. This is one of the two big radiology group in Maryland, Advanced in America. Uh, she's undergraduate from the Yale University and then medical degree from University of Virginia School of Medicine. She did diagnostic radiology residency at University of Texas, affiliated hospital in Houston. And she's a faculty at MD Anderson also. She was part of the faculty there. Her main goal is she wants to give it back to the community, and she herself being the uh, she herself being the breast cancer survivor, she knows how the things happen and how to take care of it. She also has so many other appointments, like you see on the screen. She served on the board as Susan G. Komen, the Maryland board, and the chair for 3 years. Currently, she's the secretary of the Maryland Radiological Society, local chapter of the American College of Radiology. She is specialized in the breast imaging, mammograms, sonograms, MRI. She does her biopsies also, different ways of doing biopsies, and she may be able to touch some basic how the biopsies are done. And also she has written the book, which is a very good, like it's a defeating the breast cancer, a physician's story of healing, martial arts and the life. And this is just her own cancer journey. And she just wants to encourage others facing the same diagnosis, treatment and the hope. So we welcome Stacey. Nice to be part of the panel here. Then the second great panelist is Dr. Cheston. Many of you must have heard her name. She's an undergraduate from Smith College, Massachusetts, medical degree from the University of Maryland. And since then, she's been here in Maryland. And in '96, she joined the faculty of University of Maryland School of Medicine and Department of Radiology, Radiation Oncology, and serving as an associate professor. She's also at the editing professor at Johns Hopkins Radiation Oncology and Molecular Radiation Sciences, medical director of the Central Maryland Radiation Oncology. She has dedicated her entire career serving in Howard County, people here in Maryland, Howard County, and we are very thankful to her giving us such a great service to a lot of our people around here. And her focus is mostly on radiation therapy for the breast cancer and also on general radiation oncology. So welcome, Sally. And Dr. Tejaswi Sastry, her name is Tejaswi, but we call her Teji. She is medical graduate from Bangalore, India, and internal medicine residency at Moses Cone Hospital, one of the affiliates of Chapel Hill in Greensboro. Hematology and Oncology Fellowship in Eastern Carolina University. Joined at the Maryland Oncology in Howard County and serving for last 9 years. Her main interest in the breast and gynecological cancers and lives in Potomac with her lovely husband and 11-year young son. Welcome you, Teji, also. These people are very well known. And now, this is what the breast cancer we talk about today. We know it is preventable. It is diagnosable also, treatable and curable. So these are the things that the breast cancer is about. Some numbers to just let you know, again, not like something you need to scare about yourself, but it's a 1 in 8 women will be diagnosed with breast cancer in her lifetime. So this is something very astounding, number 1 in 8.
Oh, अभी है बोला है।
Okay. So if you look at it on the side, it says like from the birth to the age of 39, that ratio is 1 to 228. From age 40 to 59 is 1 in 24. And as we get older, the ratio goes to 1 in 14. And there is a little bit details about the understanding the risk also. And I'm sure Tej is going to talk a little bit more about this too. So from 20 to 70, if you look at it, it's at the age of 20, the risk is only 1 in 1700. Then you look at like it's like a 299 or 300, 70, 40. So as we grow older, it goes higher and higher. But there is the overall risk is 1 in 8. Look at the number, what happened in 1975 and 2020. In 30, 45 years, the ratio was 1 in 11, so about 9%. Now it is 1 in 8, has gone to 13%. Granted that we are more diagnosis or more studies, or more screening is done, but these women are diagnosed sooner and they get treated also. So projection for in 2020, there will be about 17,000 new breast cancers. And this would be like 47 female being diagnosed with the breast cancer every day. This will be the number. Again, if you look at it like if you put like in a short number time, like in US, every 2 minutes a breast cancer is diagnosed. And if you look at the whole world, it's about every 29 seconds. Just one on the top side here, there are 292,000 women will be diagnosed with the breast cancer this year. And also the male can also get the breast cancer. There are about 23,000. So if you look at like there are 208 million survivors all across the world. If you look at it, there are some Hispanics and other things also. So some of the causes of the breast cancer we see here is, it is like a women these days, they don't understand much about the breastfeeding. So not breastfeeding is one of the risks. Then delayed pregnancies, again the stress, air pollution, lack of sleep, and other thing. And if you look at in the little circle, that did we know that the career women have an increased risk of developing breast cancer than people who are like in low working job or something? Again, once this is diagnosed early stage, if you look at the number, US men and women, stage 0 is 100%. Then stage 1 is also 100%, depending on how small or how it is treated and everything. And stage 2 is 93%, stage 4 is 72%, and stage 4 is 22%. So our goal is to diagnose as stage 0 or stage 1 and get the best outcome. So then that cancer is gone and is gone for good. Male also is the same thing here. Stage 0 is 100%, but many times the male breast cancers are not diagnosed at stage 0 or 1. They are a little bit advanced cancers that come in. So, but they still have a good, but not to wait till we go to stage 4. So what I'm going to do now is going to just let me go with the screening here first. So the screening criteria is breast self-examination, which is performed monthly by the woman of all ages. Then clinical breast examination performed by a physician, or every 3 years by women 20 to 40, and every year for women over 40. And also the mammography. The woman age of 40 it starts, and then once a year every year. And Dr. Keene will talk more about this also. There are some of the things how the breast self-examination is done. Most of you already know, just look for any changes. Many women tell us that they don't know what the breast feels like or what is abnormal, but anything you feel a change, that is abnormal for you. And let just your healthcare provider tell you what it is and what should be done. So it is very important because you know your body the best. So it's better just to learn about this a little bit more. And there are some signs of breast cancers also that you notice, or the physician or healthcare provider, we notice sometimes there is a change in the nipples. There may be like a nipple discharge. You may feel a lump, but whatever you feel, then it is our job to take care, make sure what it is. Okay, so I'll stop here, and Teji, you want to go next?
Sure, I can go next. Unfortunately, I'm going to try sharing my slides, but if it doesn't work, I'll just discuss a few things.
Okay.
Okay, so we're going to try again. For some reason, I'm having some technological problems here.
Okay.
Let's see. So, yeah. So Kiran, you already talked about this, but I thought I'd kind of just touch upon it once again.
Sure.
We know that breast cancer is globally the most frequently diagnosed malignancy, and it's the most common cancer in females in the United States. 1 in 8 women will develop breast cancer, as you said, Kiran. One of the things I just wanted to contrast is that in India, because of course we have, we're talking to the Indian population. In India, actually in urban areas, it's 1 in 28 women. So it seems like it's a little bit less, but what we're seeing is it has increased tremendously. And I suspect it's because more westernization is what's going on. So, and I think that's kind of the extent of my slides that are showing up, but I'm going to try. Okay, so risk factors. Are you able to see that? I'm sorry.
We can see it, yeah.
We can see.
Okay, all right. So with the risk factors, as you said, Kiran, as you grow older, individuals definitely have an increased risk of developing breast cancer. It's 1 in 14 women with individuals greater than 70 years. Again, females more than males, but males can develop breast cancer. And that's kind of the take-home message here. You'll mostly see male breast cancers in individuals who have family history of breast cancer, and also individuals who potentially could have received some sort of radiation that could increase their risk. It is more common in white women, in obesity. So individuals who are obese, and that's actually individuals who have a BMI greater than 30 have a higher risk. And I'm sorry, are you able to see my slides? I'm sorry,
Yes,
I'm not able to.
It's okay. We can.
All right, so I might have to just kind of talk because I don't think it's showing up. About fertility, so individuals who do not have any children, so nulliparous individuals have a higher risk versus individuals who have had babies. And just talking about hormone levels, because that's actually really important with breast cancer. The higher the estrogen levels increases the risk. So for example, in individuals who are postmenopausal and who are taking hormone replacement therapy, those individuals have a higher risk of developing breast cancer. Now, that's only individuals who basically have had hormone replacement therapy for at least 5 years. And that's why individuals where we used to be giving hormone replacement therapy, we stopped doing that because of that risk. Smoking and alcohol also increases the individual's risk. I also wanted to talk a little bit about some inconclusive factors that, we talk about, but potentially don't have an increased risk of breast cancer. One of them is just increased fat intake. So we always talk about, yes, we should have a low fat intake in our diet, but does that really increase your risk of breast cancer? So if you look at data, it really doesn't show that an increased fat intake increases your risk of breast cancer. Now, that being said, individuals who have increased fat intake potentially become obese, and then you have your BMI greater than 30, and that could increase your risk, but that's kind of more consequential. Kiran, you talked about the breastfeeding, and that's really important. And if you look at data, for every 12 months of breastfeeding, there is about a 4.3% reduction of relative risk of breast cancer. And that's actually, it's kind of interesting to see that. So of course, it's not only good for the baby, but also for the mom to breastfeed. Physical activity. So we know that individuals who exercise on a regular basis, it does decrease the risk of breast cancer. And individuals, we also know that individuals who've had breast cancer and they exercise, and when I say exercise, only about 30 to 40 minutes, about 3 or 4 times a week, that decreases the risk of recurrence. I also wanted to talk about genetics because that's important. So we always talk about family history, and it is important that individuals who have a family history have a higher risk of developing breast cancer. But knowing that it's only 10% of breast cancers which are actually genetically related. So it's important to know that 90% are not genetically related. So it's good to know your family history, but it's not the end all and be all. Additionally, when you're talking to your family, I mean, and you're asking about what their family history is, it's not only important to know what if they have breast cancer, but kind of going into details like breast cancer less than 45 years of age, a triple negative breast cancer, male breast cancers, any ovarian cancer, pancreatic cancers, prostate cancers. Those are things that you should get from your family members to understand what your risk is. And one other thing about genetic testing, so of course we do BRCA testing, which is BRCA1 and 2 testing, plus a whole host of other genetic tests to see whether a person has an increased risk. If a person is positive for those genetic mutations, those individuals have about a 70% risk of developing a breast cancer in their lifetime. So it's really important to find those high-risk individuals so that we can screen better. So I am going to stop sharing because it really wasn't sharing, and let Stacey take up on the screening. I'm sorry. I hope you were able to understand.
Yes, yes, it was very good. So what we will do, just like all for our listeners, if you have any questions, we can just address at the end after all the presentations are done. Thank you.
Can you hear me okay and
Yes.
see my screen?
Yes.
So I'll just talk about the role of breast imaging for the diagnosis and screening for breast cancer. We've just heard about all the risk factors and the statistics. So the basic purpose of a screening is to find smaller tumors where the prognosis is better. Prognosis is also related to the presence of axillary lymph nodes and the characteristics of the tumor cells themselves, with which I think Dr. Sastry will go into, the hormone receptors on the tumor and the aggressiveness of the tumor cells. And Dr. Parikh mentioned how we do the early detection of breast cancer with screening mammography, clinical breast examination, and knowing what's normal for you. So there are two ways or two reasons for doing mammography. One is screening, just to search for unsuspected disease in asymptomatic patients. And the other is diagnostic, to pursue a particular problem somebody might be having. Since the widespread use of screening mammography began in 1990, we've seen over a 40% reduction in breast cancer deaths. And that's in part due to screening, finding things earlier, but also to improvements in treatment. And it's also important to know that more lives are saved by beginning screening mammography at age 40 rather than later at 50. And the American College of Radiology and Society of Breast Imaging also recommend that all women be evaluated for breast cancer risk by age 30, and particularly in the populations that have a higher risk of the genetic mutations for breast cancer, and that's African American women and Ashkenazi Jewish women. By identifying people at higher risk, we can do supplemental screening, and that includes using breast MRI. So in somebody with a known genetic mutation, we recommend starting MRI screening at age 25 and then mammography screening at age 30. And also other high-risk women with a history of breast cancer, especially before the age of 50, and women with a high-risk biopsy should start annual screening MRI to supplement screening mammography. And finally, those with a history of chest radiation, like for Hodgkin's lymphoma, before the age of 30 should have mammography starting at age 25 or 8 years after therapy, and then start annual screening MRI at 25. You may have heard about breast tissue density, and we are now we inform people if they have dense breasts. And this is an example of all the different breast tissue densities that are found. Normal breast tissue is comprised of fatty tissue, which appears gray on the mammogram. These are side views of mammogram. This is the muscle. And then the fibroglandular tissue appears as white, these little strands that you see. But also breast cancer shows up as white on a mammogram. So you could see how a breast cancer could be masked in dense breasts, which are the heterogeneously dense or extremely dense breast tissue. And there's also BI-RADS, which is a breast imaging reporting and data system, a standardized system of reporting developed by the American College of Radiology. And this helps us describe findings in a uniform way, as well as uniform recommendations and assessments of findings. So there are normal or benign findings where we recommend annual screening mammography. And then there's those in which we recommend a short-term follow-up of a probably benign finding like a little complicated cyst or a benign mass. And then there are the BI-RADS 4 and 5 where we're suggesting biopsy or surgical consultation, and BI-RADS 6, a biopsy-proven malignancy. That's used when somebody is having like an MRI for diagnosing extent of the breast cancer and to check the opposite breast. So of every 100 mammograms we do, approximately 90% of the patients are called back, come for a year later. You know, we recommend a screening mammogram, and about 10% are called back for either additional views or an ultrasound. And among those, most of those are invited back in a year once everything is cleared up, like for a benign cyst on ultrasound. And about 2 of the 10 women, they'll be asked to come back in 6 months for a probably benign finding, and maybe in 1 to 2% of the 100 will recommend a biopsy. And we try to do minimally invasive biopsies, just needle biopsies, guided by either mammography, ultrasound, or MRI. And even among these biopsies, most of them turn out to be benign and not cancer. So the type of mammography we do is digital mammography. This has come a long way since when I first started. We did Xerox mammography and then film screen, but digital mammography, the images are displayed on a computer. And now we're doing 3D mammography, which takes images like slicing through the breast tissue, like the pages of a book, rather than looking at the cover of a book, so we can see greater detail. When we interpret the mammograms, we have computer-assisted detection, and it can't replace people, but it certainly can assist our diagnoses. And then there's something new on the horizon, contrast-enhanced mammography, which I'll briefly mention. The advantages of the 3D over the 2D mammography is that it minimizes overlapping structures, so we can see through the dense breast tissue better, and it increases sensitivity for detecting cancers and also increases specificity of findings. This is just a comparison of all the imaging modalities, and the FFDM is just digital mammography, and we can find like 7 to 8 cancers per 1,000 women. With the addition of 3D, we can find an additional 1 to 3 breast cancers per 1,000 women. Adding ultrasound to conventional digital mammography, we can find additionally 4 breast cancers per 1,000 women. And MRI is the most sensitive of all. We can find an additional 15 breast cancers per 1,000 women using that. What we look for on mammograms or signs of malignancy include a mass, calcifications, and other subtle findings like a new asymmetry in the breast tissue. This is an example of a diagnostic mammogram. The triangle denotes something the woman could feel. She had a palpable mass. As I pointed out before, the white is the fibroglandular tissue and the gray is the fatty tissue, and this is the muscle. This is the right side and this is the left side. So this is the normal breast on the right side. And here, where the patient could feel something, you see this mass, a round mass projecting up. And that did turn out to be a breast cancer. In addition, all these little white dots all over, these are suspicious microcalcifications. And she turned out to have involvement by cancer of the entire breast. This is an example of the benefit of 3D versus 2D mammography. They're both the side view of the same breast, and the white is the glandular tissue and the gray is the fatty tissue. It's a little whiter in here, but using the 3D, you can see the emergence of this mass with little spikes, spicules coming out of it, and that turned out to be a small breast cancer that was picked up on a screening mammogram. This is an example of contrast-enhanced mammography. The vascularity of a breast tumor, of a breast cancer, is different from the normal breast tissue. Breast cancers make a lot of little vessels grow within them, and so they take up contrast and blood supply very quickly and drain it out quickly compared to normal breast tissue. So this is the regular digital mammogram, which shows the dense white fibroglandular tissue. And here's a kind of a wider area. With contrast enhanced mammography, contrast is given and a mammogram is taken, but it subtracts out the normal breast tissue, and you can see this mass. MRI works in a similar way in that we give intravenous contrast that shows the abnormal vascularity in a mass. It just shows the soft tissues in a little more detail, but it's a similar concept. Other modalities that we use for evaluating the breast include ultrasound and MRI, as well as nuclear medicine imaging. Please note that thermography is not proven of any benefit in the screening and diagnosis of breast cancer. It's been around since the 1970s, and there's still no data to support its use. So breast ultrasound is useful for screening to pick up in high risk or intermediate risk women with dense breasts. It's also used when something is felt or seen on a mammogram to determine whether it's a benign fluid-filled cyst or a solid mass, and if it's solid, whether it's suspicious for malignancy or it looks benign. In women with dense breasts who feel something and nothing shows up on the mammogram, it's used, as well as in patients either too young or who are pregnant and shouldn't undergo the radiation from mammography. Finally, if something is found, it's a good guidance for intervention through a needle aspiration or core biopsy, and it can be used to help the surgeon localize the lesion before surgery. This is an example of a benign cyst versus a benign solid mass, and both are very smoothly marginated and oval, but you can see the cyst is very black on ultrasound, and solid masses have little specks in them. This is a malignant mass. You can see by the shape, it's rounder, and it's got these little spiky margins. And we used breast MRI, as I mentioned before, for high-risk screening. And then if an abnormality is found, we can do MRI-guided biopsy. It's also used if somebody has a problem like a nipple discharge and the mammogram and the ultrasound are normal. It can often pick up a source of the nipple discharge, like a little growth in the duct. And then once somebody is diagnosed with breast cancer, it's helpful in determining the extent of cancer in that breast or the opposite breast, and to see the response to chemotherapy. If somebody has abnormal axillary lymph nodes and there's nothing seen on the mammogram or ultrasound, and there's metastasis documented by a biopsy, frequently MRI can find the source of the breast cancer within the breast when it wasn't seen on other modalities. This is an example of the use of MRI in determining the extent of disease in breast cancer. Here's the mammogram, another side view with the white fibroglandular tissue. This is a small mass that was picked up on the mammogram and found to be a breast cancer. This is the MRI that was used for staging, and here's the mass. But additionally, other areas of involvement by cancer were found in the breast, and very large lymph nodes, metastatic lymph nodes, were seen on the MRI, which were not really apparent on the mammogram, just a suggestion from the corner of the mammogram. Nuclear medicine imaging is used to guide the surgeon to the abnormal lymph nodes if they're not palpable when they're doing a biopsy. PET scans, along with PET CT, are used to determine metastases throughout the body to see if they're there. Then there is other nuclear medicine imaging called molecular breast imaging, sestamibi tumor imaging, and positron emission mammography, and there's being work done on these modalities. This is an example of a PET scan from a PET CT, which shows a bunch of little lymph nodes involved by breast cancer that were not before suspected. And then treatment, everybody else will go into that: surgery, medical therapy, and radiation therapy. So we've really seen a tremendous decrease in mortality from breast cancer through improvements in screening and treatment. And we're more sensitive in picking up early breast cancers, but our hope for the future is to prevent it altogether. So I'm going to stop sharing now and let somebody else have the floor here. Okay.
Thank you, Stacey. That was so nice, very nicely explained. Very nicely. So let me just go back on. Okay. Yeah, Sally, I'll just get you. So once the diagnosis is made, let me share 1 second. So I'll just go a little bit here. So once the diagnosis is made, these are some treatment options we have. One is surgery, radiation, medications like hormones or chemotherapy, or complementary treatment like yoga, acupunctures, and everything. Now, this all depends on, so this is just like what this Stacey was talking about. Even with all these screening modalities we have, this was a good slide I think I'd like to share with you. If you look at this, it has done in the different parts of New York, like in New York State, then upstate New York and everything. In spite of all this available between age of 50 and 74, only 80% complied with these screening things. And so, the society is trying as much as possible for people to get involved in their own care, but still there are like 1 in 5 will still not be following those kind of things. So the breast cancer treatment depends on the, first of all, type of a cancer. Sometimes there could be non-invasive, could be invasive cancer, ductal or lobular, and there are all different other types also. And the treatment options, stage of the cancer, type of the cancer, age of the person, health of the person, and then the cycle as well as from the history, like a family history of breast cancer and other thing also. In the surgical options, what we do, Dr. Keene just mentioned a little bit about it. We do, there are 2 options we have. One is called a lumpectomy, means to preserve as much normal breast tissue as possible, but remove the cancer and the surrounding tissue around the breast cancer. So that's part of the lumpectomy. And this is how it is done. Let's say in this picture, you see a cancer was here. So not only remove the cancer area, but remove some of the tissue, normal tissue around also. Because the important thing is to make sure that all the margins are clear before Sally talks to the patient about the radiation. And sometimes we do the lymph node biopsy also, which is as Dr. Keene just mentioned about. So this is where the important thing about the margin when we do the lumpectomy. So if this is a cancer here, then this margin has to be taken out some more here. And this next picture tries to explain also, in a lumpectomy, adequate margin is, if this is yellow part is a cancer, you take out the surrounding breast tissue around, so that's called a negative margin. It has to be all around. And if you see here, the right side picture, there is a yellow part is extending to the margin here. So that's called inadequate margin. So then sometimes you have to go and take it out more tissue, make sure it is all clear, because it's very important for Dr. Cheston and all of the radiation oncologists to make sure the margins are clear. Look at the trend, how things have changed in last 20 years. There used to be a lot of mastectomy before the radiation and lumpectomy and all other things started. Mastectomy was the only treatment. I remember during my early practice and residencies, women had a breast mass, they go to sleep, and when they wake up, if it is cancer, the breast is gone. So those days there was no option because there were no other modalities available either. But now look at how many mastectomies done and how many lumpectomies are done. 35% as well as 65%. So this is a big change which happened now. And this is good for change also. This is a node biopsy. When you have a cancer, sometimes you have to see whether the cancer is spread to the lymph node. That is mostly to stage the cancer, to like a stage. If it is only limited to the breast, it can be stage 1, goes to the lymph node, becomes stage 2. This was why a very novel surgeon, he was the John Wayne Cancer Institute in California, named Armando Gugliani. He just was working on something one day and then found out this lymph node technology. It's a wide, rather than taking so many lymph nodes, he decided, or he found out that taking first 2 or 3 lymph nodes, and if they come back negative, then there is no need to take some more lymph nodes out. Let's see what we have. Okay, and so this is Sally will talk about also. So this is just a nutshell. There is also mastectomy. Okay, so other option is a mastectomy also, where you not only remove where the cancer is, but they take out the whole breast with the nipple and areolar complex, and as well as take out the lymph nodes also. Some mastectomies, you don't have to take the lymph nodes out. Some you take out the lymph nodes to make sure that it's for the staging purpose also. And after the mastectomy, the woman does have an option for a reconstruction, and this was mastectomy reconstruction in 1998. The Year of the Women's Health and the Cancer Right Act was passed. It was most insurance companies were told that any woman who is wishing for a reconstruction after mastectomy, they should be covered. They should not be charged like a plastic or cosmetic surgery or anything. It is a part of the cancer treatment. And 77% of women don't even know that they have an option of reconstruction. And more than 50% they know, but they may or may not go for it. So there is an option for doing a reconstruction also. All right, so I'll stop sharing now. Sally, please go with your radiation part now. We'll hold up for our questions and then ask the panel later on. Thank you.
Can't hear her.
Can you unmute Sally, please?
Got it. I just figured out how to do that. Okay. Okay, and my screen, my slides are up. Is that
Yeah,
right?
it is up.
Okay, I'm going to talk about breast radiation therapy in the year 2020, but radiation therapy is sort of the unknown specialty. So I just want to go over that a little bit. Can you hear me okay?
Yes,
Yes.
very clear.
And so what is radiation therapy? Well, this is where we target high dose X-rays that we generate in our treatment machine towards tumor cells within the patient. And so this is what a radiation treatment room looks like. This is the head of the machine where the radiation comes out. Here's a patient lying on a table. The arc of this radiation machine rotates around 360 degrees, and the treatment table slides in and out. In this table also rotates around like this. This is important because we're trying to target this beam at a tumor structure within the body. So just briefly, how does radiation therapy work? We no longer have radioactive materials for the most part
Can you mute her, please? I think it's Suthar.
In our treatment room. So we generate the radiation. I'm not going to get too technical, but basically we turn on the electricity and electrons go into something called a linear accelerator, which accelerates the speed of these electrons. And then they are bombarded on a heavy metal target. And that interaction causes the generation of photons or X-rays, they're synonymous, which we point towards the patient. What's happening in here actually is this stream of electrons is veered off course by its interaction with the nucleus of the molecule within the heavy metal target. And just like a car going around a turn, there is energy emitted with that. There's a transition of energy, and that energy is photons. On the other side, we have the patient lying here, and we are made up of tissue, which is made up of cells, within which are the nucleus, and within the nucleus are chromosomes or the DNA. And what happens when the photons hit the tissue of the patient is the energy of the photon interacts with water molecules, breaks it into a free radical, which then can damage the DNA or just knock an electron off and damage the DNA. And so that's the connection between photons and the DNA of the patient. And you may be saying, well, gosh, not every tumor cell, not every cell is a cancer cell. Why isn't the radiation damaging everything? And the fact is, yes, the radiation is doing damage to normal cells as well as cancer cells, but we get a differential that helps us a great deal. When the DNA itself, when it's damaged, that doesn't cause the demise of the cell. It's only when the cell subsequently attempts a cell division that it can't orchestrate that event, and so the cell dies. We have two properties at work that favor the cell death of cancer cells over normal cells. One is that normal cells can repair DNA damage, whereas cancer cells cannot. So if the DNA is repaired before the normal cells attempt division, they survive, whereas the cancer cells will not. The other thing we have going for us is that cancer cells in general attempt cell division more frequently than normal cells do. Some normal cells will not repair the DNA damage in time, and especially the rapidly dividing cells like skin. And so we see skin toxicity from radiation as a result. Next question is, how do we get the radiation where we want it to go and protect precious normal cells as structures? And there are several techniques that are very important in radiation therapy. First is mobilization, keeping the target still and in a position that's reproducible day to day. Then it's good imaging of where that target is within a patient. And then planning how to deliver that radiation, and then having the tools to, essentially what we're doing with radiation is trying to deliver a cloud dose of radiation to the area at risk for harboring residual cancer cells. And then there's rigorous quality assurance. And this is very, very important. I can't stress it enough. It's very important that the therapist at the machine pay meticulous attention to details. We always double our staff on the machines so that people are checking one another. So there's the daily measurements that are important. We have 2 full-time PhD physicists checking over all plans and also keeping the quality of the beam of radiation. It's checked every single day, and then it has monthly and quarterly QAs. Then every single treatment plan that we generate, we go over with our colleagues of doctors and other staff, and we present the case and determine, is this the right treatment program for this patient, and does this treatment make sense? So a lot of QA, and the old adage in carpentry is measure twice, cut once. In radiation therapy, it's evaluate 30 times and administer the course of therapy once. So let's just create a breast cancer treatment plan. I have something that's blocking my view. Okay, first of all is immobilizing the patient. So here's a woman, who, she's a model actually. And what we have here is an immobilization device, which is very fancy. It's a bag of beads. And we have her lie down against it and make her impression into the bag of beads. And once we're pleased with her comfort level, as well as a setup in terms of how we administer the radiation, we suck the air out of that bag and it maintains its shape. So that patient lies exactly in that position each day. And then she goes into the simulation to capture the images. So this is the CAT scan. And this table will slide in and will capture images of her. And what a CAT scan does is to take a patient's body like a loaf of bread and slice through so that we get these multiple images or slices of that patient. So here's the kind of image we might capture from this CAT scan. Can you see my cursor? Is that?
Yeah, we do.
So white is bone. So here's the backbone and here's the sternum. In CAT scan images, the right side of what we're seeing is actually the left side of the patient. So this is the heart and these are the lungs. And this is just a dome of the diaphragm. It's not a mass in the lung. And then of course, here's the breast itself. So all of these images are then sent over to my desk in my computer, and I begin to outline the structures that we want to target. So for instance, in this patient, the surgeon was kind enough to leave a clip behind to help me outline the tumor bed. And I can also see changes in the CAT scan that demarcate the lumpectomy bed. I create a little bit of expansion on that as my target so that we can accommodate for daily treatment movement. And then I also outline the entire breast tissue, okay? Almost as important, we also outline structures we wish to avoid. So in breast cancer, that's generally the lung and the heart. Then I'll put on beams of radiation to treat this. And so one option would be to have one beam coming straight down to the breast. The problem is that beam would be exiting through the body and giving radiation dose to a great deal of lung and also to a portion of the heart. So instead what we do is to angle the beam over and give one beam from this direction and one beam from this direction, skimming the fields tangentially across the chest wall. The problem with the shape of the breast is that it is sort of shaped like a pyramid, except for the base or the floor of the pyramid is convex. So in order to, if we use these two angles, then in order to get all the breast tissue in the corners, we end up going through a little bit of normal lung tissue and a little bit of chest wall, which we follow rigorous guidelines for how much is acceptable and would not cause the patient problems. But in any event, we would prefer not to treat that lung. Sometimes it's important to treat chest wall, but we prefer not to treat that lung. But I'll get back to that in a minute. And so then if you were to look at what that X-ray would look like, this is similar to a mammogram. We're viewing the side of the breast, and this rectangle is the area that's being treated with the radiation, and all these areas, the gray blue, are being blocked. So you can see that the outlined breast is fully covered in the field, as is the lumpectomy cavity. The heart is protected. Unfortunately, a little bit of lung is in the field of treatment. So if I said that, so another question is, how do we conform the radiation dose? If the breast is shaped like a pyramid and the base is very thick and the apex is very thin, if we have just an equally weighted beam, we will overdose the apex and underdose the corners here. So what we do is we treat with multiple fields from each angle. And we might have an initial field that's completely open here, treating all of the breast tissue. But to accommodate for the fact that there's less tissue anteriorly here, we'll block. So we'll turn this beam on for 10 seconds or 15 seconds. And then we close down the anterior portion of the field to block and protect the nipple area and the other apices of the breast, and turn on the beam for another 10 or whatever is precisely prescribed. And then give a little bit more to that thick base. The idea being to deliver a very homogeneous dose to the whole breast. So does every patient require the same dose and treatment volumes? And the answer is absolutely not. And increasingly, we are splaying out the various treatment options for our patients. These are determined by the tumor characteristics, by tumor cell characteristics, and also by patient characteristics. And I want to say that in the consultations, we spend a lot of time on the patient's desires and expectations, because in a lot of early breast cancer cases, which over 60% are, women have choices about what kind of surgery, about what kind of radiation, about whether they want the most aggressive of all treatments. So we go through that. And it's very interesting and it's worthwhile to spend the time having this perspective, because some women will do very little to improve their chances by 10%, and some women will do everything to improve her chances by 1%. So the goals of breast cancer therapy are to cure the cancer, obviously, but we're doing everything we can to minimize side effects. Also, we want to maintain quality of care. It's also important to talk about maintaining breast cosmesis, which many women say, I'm not vain, I don't care what it looks like. So I like to use the word normalcy instead, because we're trying to cure, but we're trying to keep people as normal as possible. And I try to say to people, think about 5 years from now when you're going to the beach with your grandchildren, you put your bathing suit on and you look at your breast. It would be best if you not think about the breast cancer and it's as normal as possible so you can carry on. So just kind of where we're going with radiation therapy in locally advanced disease, and I really can't cover all this, I'm sorry to say. We're treating with more conformality and with newer modalities. We have intensity modulated radiation, we have proton therapy, we have thermal therapy. Heat seems to make cancer cells more susceptible to radiation cell death, and increasingly concurrent radiation with systemic therapy, be it endocrine or hormonal or immunotherapy. With early disease, we're treating with shorter courses. It used to be 6 weeks for everyone. Instead, the standard of care has now become 4 weeks. We're trying to treat patients face down rather than face up to protect the heart and lung. In some well-selected patients, we can treat just a portion of the breast because only the area around the cavity is at risk in appropriately selected patients. And then no further radiation treatment is getting to be a viable option as we understand more and more about individual cell biology. I'll show you a modality where we think perhaps we can even replace surgery with radiation therapy. So just, I'm worried about time a little bit, but.
No, you have time, Sally. Just
Okay, thank you. For years and years and years, we treated everyone face up. This is an example where that is no good. This beam of radiation, in order to capture all of the breast tissue, is actually also transecting a portion of the heart, a lot of lung, and a portion of the heart. So if instead we have that patient lie face down so that one breast is through the hole of the table and the other breast is sort of swept to the side, so she's got a lot of pressure on that breast and on the sternum. But this is really helping in 2 arenas. One is that the breast falls away from the chest wall and from the heart. And secondly, that pyramidal shape becomes more tubular and it's easier to give an even dose of radiation through that breast.
Very nice, very nice.
So let's say we have a woman, and because of Stacey's excellent screening, we pick up so many women with very early breast cancer. And let's say they have low risk features, which I can't kind of go into in too much detail, but studies have shown that just treating around the lumpectomy scar itself seems to be adequate and controls the disease with only a 2 or 3% risk of it coming back in the breast. The beauty of treating a smaller volume of the breast tissue is that we can increase the daily dose, and we can shrink it down to as low as 1 treatment to about 5 treatments, which is tremendously convenient for patients. This idea has been around for about 30 years, but there's been a good evolution of how it's delivered, and I'm going to go through that a little bit. One is to do brachytherapy, and in this situation, radioactive material is inserted into the breast after the lumpectomy, after they've evaluated the characteristics of the tumor. Catheters are placed into the breast. In the original were multiple catheters placed into the breast, and then radiation would go through these small catheters and dwell and emit radiation. And this was a really good treatment in that you could make very funny shapes of your radiation dose cloud, but it's pretty invasive, as you can see. This is more modern, to use balloon therapy, and you insert one balloon into the cavity, expand it, and the radioactive source comes through this catheter, dwells here, and emits radiation. This is easier on the patient, but you can see that this is sort of an artificial looking cavity compared to what more normally happens. There's something called intraoperative radiation therapy, and this is when the patient has radiation at the time of her lumpectomy. A strong argument is made for doing this in areas like the Dakotas, for instance, where people travel literally hours for their treatment. So in this situation, the woman is in for her lumpectomy, and when the lumpectomy is completed, this little radioactive device is placed into the cavity, and then radiation is emitted right at the localized area. Then this device is pulled out and the wound is closed. This is my least favorite of the APBI, or the partial breast irradiation techniques, because not only does it require a lot of overhead and dedicated training in the OR, but also you're administering the radiation therapy prior to really knowing what this patient's full tumor risks are. For instance, whether her margins are negative or whether she has lymph nodes where she would need radiation more comprehensively. The other thing is that from a radiation oncologist's perspective, the dosing cannot be adjusted for oddly shaped cavities. So we worry, we can't really evaluate how well the dose was actually delivered. Then there's 3D conformal partial breast radiation. I can do that and have done that here in my office. It's very appealing for radiation oncologists because most of us have the tools to do it. But in fact, so what it is to deliver multiple beams of radiation from multiple different angles at the lumpectomy cavity. The problem with this is that mostly when patients are in the supine position, face up, the breast is not immobilized as well as we would like. There's a little bit more movement, and therefore we create a larger target in order to accommodate for that movement. And a very large amount of breast tissue is therefore irradiated to high doses. And so what we have found over time is that we've had patients with long-term side effects that we didn't like, especially chest wall pain and poor cosmetic result. So we're really not doing that. So that brings us to the next thing, and this is a device called the Gamma Pod system, and it was invented in our department by one of my colleagues. This is a device where the woman lies on top of this table, her breast falls through the hole, and within this area are numerous radioactive sources that all converge on one point in space. And so here's the woman, and here's her breast falling through. We have her immobilized in little cups. So there's an inside cup and then there's an outside cup. A little bit of suction is placed on here to keep the breast absolutely immobilized. And here is the lumpectomy cavity, our target. And here are these numerous radioactive sources. Their aim is all converged in this area. So if you want to begin by radiating this area, you can, but if you want to then give more radiation down here, you simply lift the patient in on the table to cover, so that epicenter of that focus of the radiation stays the same, but the patient moves around in order to cover those areas. These are what the cups look like for various breast sizes. This is the seal that goes against the chest wall. This is the catheter. This creates a little bit of suction. And then this inside cup is attached to a cup that is has fiducials attaching it to the treatment machine. I'm sorry. And this is just a look at how the dosing occurs, or the targeting of this lumpectomy. And then this is the actual dosing. So the red represents the prescribed dose, and these others are lower doses that occur, but a lot of the breast is not getting any dose at all. The chest wall is protected. And even on this image, you can see only a portion of the breast being irradiated. This is a YouTube. We'll see if it'll be, I'll go through it quickly if I can, if it connects. If it works, Shlok will be very proud of me. So here's the Gamma Pod device.
You can't see it.
You cannot see it?
No.
Yeah, I think there's a slight delay.
Okay, so you cannot see it?
No.
Okay, I'm gonna just carry on then.
Okay.
Sally, you may have to share a different screen.
Oh, yeah.
So switch the screen, please.
Am I running out of time? It's a 2-minute video, but is the time?
Please show it. I mean, it's very interesting. Is it okay for all our listeners just to look at this 2-minute video? Okay, good.
So, yeah,
Sally, stop sharing,
Yeah.
and then you'll be able to see the other screen and start sharing that.
So while she's doing that, this is amazing how detailed she has talked about. Sorry, it may be a little bit more for you guys, but it is something nice to know what 2020 can do for us, how technology has evolved, and how it is helping the people. It's very precise and everything. And if she has time, she can even talk about proton therapy for a minute or so.
can you see this?
Yes.
Okay, so this is the gamma pod, and it's nifty because the patient will actually step up on here.
Ooh.
She has the cup around her breast, and then that goes into the machine, and it is attached to the machine, so there's no movement.
Wow.
And then this table goes up and locked into position, and then the stand goes away. And then the bottom of the machine is opened up so that, yeah, so that's the bottom of the machine where all these multiple beams of radiation are targeting that spot in the breast. So it'll deliver radiation to the edges first, and then use a different aperture of these sources to fill in the center.
Outstanding.
So that gives a very uniform dose distribution within the breast. And after the procedure is finished, it closes, the table raises, the bottom attaches, and she is lifted off the table.
Oh, God. How long does it overall take for the start to finish?
Yes, really good question. And so I'm going to just knock that out.
Okay.
And then, sorry.
It's okay. We can hear you clear.
Can you see this? No, you can't.
No.
All right. So basically it takes about an hour per session to go through the entire course of that. I'm sorry, I'm not screen sharing. I don't know how to, let me see this.
Yeah, that's all right.
I can do it. I think I got it, I think.
Okay.
Back to you. I'm gonna knock that out. Are you with me here?
Yeah, we're still here.
Yeah, I'm not gonna get back to it. I'm sorry.
That's okay.
So it takes about an hour, but the beauty is that that is administered only 5 times, and it's very localized. Our hope is, and that's, you can see that that's a lot more conformal radiation therapy, and it is a lot less invasive than some of the other procedures. Our hope is that perhaps we are utilizing this, but what we're doing in clinical trials is to give radiation, this kind of radiation, before surgery. And we're not giving radiation doses that we would expect to fully ablate the tumor, but we're just trying to, because we don't want to mess up the surgery, quite frankly. But we're seeing what percentage of patients will have a very good response. And thus far, at suboptimal doses, about 15% have a complete response. So we have a model for this in lung cancer, in that early stage lung cancer, tumors 2 or 3 centimeters who, you know, typically the chest would have to be open and the tumor removed, but a very 80% chance of cure. We know that we have been doing over the last 5 years just localized radiation therapy to those tumors with equal outcomes to surgery. So that's the model, that if we can be less invasive and equally effective.
Very good. Thank you, Sally. Very nice. Absolutely. I learned a lot today about radiation.
Thank you.
Thank you. So far we talked about diagnosing, doing the mammogram or ultrasound first, then do the biopsy, diagnose cancer, and then talked about surgery and radiation. But now there is still another piece to the breast cancer, is systemic therapy, which is giving chemotherapy if necessary, and also any kind of anti-hormone therapy. I'd request Dr. Sastry just to throw a little light on the systemic therapy also, please, Teji.
Absolutely.
Yeah.
Actually, Jyoti's going to actually share my slides. I sent them to her.
Oh, great. Thank you. Very
Thank
nice.
you so much.
Okay.
All right. So Sally, thank you for that. That was actually really good. When we talk about, so Sally works on local treatment and kind of local, decreasing local recurrences. And when I think about breast cancer on my side, I usually kind of talk about, okay, what can we do at this point to reduce the risk of systemic recurrences or cancer coming back in other areas of the body? Maybe not then, but probably in 3 to 4 years, or maybe up to 5 to 10 years. And so things that I do on my end are to reduce the risk of that occurring. I'm actually going to, so we're going to go to the next slide. And so again, just the treatment. Kiran, you talked about the surgery, which is important, of course. Radiations is, of course, also very important. And the two last things, the chemotherapy and hormonal therapy, is what I deal with. And then we're going to talk a little bit, and we're going to go to the next slide. So on that slide, this is a talk that I give to all my patients when they come to see me. So it's when I sit down with a little piece of paper with this picture on it to kind of explain to individuals what I look at to say, how can I reduce the risk of your breast cancer coming back? And so if you take a cross section of the breast, look at it from the side, what you're going to see is you're going to see the back muscles, you're going to see the fat, and then, of course, the functional part of the breast. And so with the functional part of the breast, of course, you have the lobules, and the lobules are kind of like that sac-like area that you see. And then you have the ducts, and the duct basically, again, the function of the breast is when you're lactating is to produce milk and for babies to drink milk. And so if you take a cross section of one of those ducts, and we're just talking about ductal cancers here, but of course, cancer can arise from any portion of that functional part. So if you take a cross section, what you usually should see is a whole bunch of cells lining that duct. And what happens in cancer is that those cells start multiplying very gradually. And if you kind of go from top to bottom, they become a little hyperplastic, then become atypical, and then develop into what we call DCIS. So DCIS is stage 0 breast cancer. This is what usually shows up on a mammogram. And that's kind of the most important reason to screen, because you can detect it at this point. But with DCIS, of course, that's a stage 0. But if the cells continue to be there and they continue to grow, then become microinvasive, so they start breaking out of that surface of that duct, then become an invasive breast cancer. And that's where you have different stages. So you have stage 1 through 4, depending upon whether lymph nodes are involved. Of course, the stage 4 is when the disease has spread to other parts of the body. So then with the next slide, what we have is, so these are the kind of the important pieces that I look at. Of course, margins are important, kind of the size of the breast cancer is important, so the stage is important. But then the details that I look at with a pathologist is, so we talk about hormone receptor positive, HER2 positive, or triple negative. So what does that mean? Well, about 65 to 75% of breast cancers are estrogen positive. That means that the cells are actually responsive to hormones. So hormones cause the cancer cells to grow. So that gives us a target. So if they're HER2 positive, which I have a slide in a second, basically that shows the protein on that surface. And if that HER2 is positive, it also gives me a target. We like targets because those are the ones that we can use to use different therapy modalities that can actually reduce the risk of cancer coming back. Now, when people talk about triple negative breast cancers, those are the ones which are estrogen negative, HER2 negative, and progesterone negative. So basically, they don't have the hormones and they don't have the HER2 component, but it's still treatable, but it's just that there's no potential target there. So then we're going to go to the next slide. So just to kind of describe. So on the left side, you see the normal breast cancer cell. And so you have protein receptors on the outside, and the inside you have 2 receptors, which is the estrogen receptor and the progesterone receptor. On the right side, you have the cancerous breast cell. And so with the cancerous breast cells, again, what happens is that either that HER2 component increase, so all those little purple line, kind of, I would say, squigglies that you're seeing outside, and then the inside is basically when the hormone receptors increase. And that's actually what causes the growth of the cell. Then you're going to go to the next slide, which is going to talk about the HER2 expression. So again, on the left side, you have a normal breast cancer cell. And there you have, again, the nucleus, and you have the HER2 receptors. Now, everybody has HER2 receptors, but those HER2 receptors have to propagate significantly, like as on the right side, and that becomes your target. Because we have drugs that literally target that HER2. And that's very important because that tells me that I can give a certain drug and that will block that HER2 to reduce the growth of cells. So we're going to go to the next slide. And I'm going to just touch briefly on hormonal therapy. And of course, I'm available to answer any questions just because it becomes very complex. What we do, when we talk about hormonal therapy, remember what we're talking about is drugs that actually reduce hormones. So it's not giving you hormones, it's actually doing the exact opposite, right? So we don't like hormone replacement therapy because that basically increases the risk of breast cancer. But what hormonal therapy, even though we call it hormonal therapy, does is that it suppresses your hormones. So if your cancer cell has that hormone sensitivity, it reduces that hormone level in your body. And what that will do is actually starve the cells, so reduce the risk of growth. And then depending upon the menopausal status, if a person's premenopause, we pick tamoxifen, which is, people probably have heard about that. And then people who are postmenopausal, we ideally use aromatase inhibitors. So the way the target is a little bit different. Tamoxifen mainly targets the ovaries, whereas aromatase inhibitors in postmenopausal individuals, it tends to target the fat in the bodies, which also produce hormone, as well as the adrenal glands, which produce hormones. So it's a blocker. You might have heard treatment can anywhere between, it can be between 5 to 10 years. So you probably hear about people taking a pill for 5 years or 10 years. And that's the hormonal or anti-hormonal therapy that we give. We're going to go to the next slide. So chemotherapy. So how do some individuals get chemotherapy and some individuals don't need chemotherapy? Well, there's several things that we think about before we decide on chemotherapy versus no chemotherapy. Well, one of them is the stage of the cancer, right? Because if you have lymph nodes involved, then we worry that cells would have gotten to the lymph node, and from the lymph node would have gotten to other areas of the body. We look at the HER2 status because individuals who are HER2 positive should get chemotherapy. We look at triple negative breast cancers. Again, remember there's no target there. So whatever treatment we give, we try to reduce the risk of recurrence, and that's why chemotherapy is offered. So that's a large component of it, but there are other small, subtle things that we look at to say whether a person should get chemotherapy or not. So we're going to go to the next slide. So just to touch upon, again, I'm open to answering any questions because it does get a little complex. With the, hope is always there, right? So the best thing about cancer is that every day things change. Every year we have new drugs that are coming into the market that actually help us treat cancer, specifically breast cancer, because of course, since it's such a common cancer, we want to make sure that we have treatment modalities that treat it. So with HER2 positive breast cancer, I would say the first drug, of course, was Herceptin. And with the event of Herceptin, that was kind of an oncological change in the whole community. Things changed dramatically when people were able to get Herceptin because it reduced the risk of breast cancer. Now, in addition to Herceptin, we have about 4 other drugs that we can give for HER2 positive breast cancers, which is amazing. So it's just that things are progressing. We're getting better at treating cancer. So yes, ideally, we want to reduce the occurrence of cancer, but even if individuals get cancer, we can actually treat them. And then just a quick note about immune therapy, because of course, everybody's heard about immune therapy. It's actually amazing. So in triple negative breast cancers, we're able to use immune therapy now. Now, they are looking into using immune therapy for other cancers too, not necessarily only triple negative, but that's still in process right now. I think that might be my last slide. Yeah, just questions. All right, Kiran.
Good, very nice. All 3 of you did a great job. Thank you so much. Now, just let's open to any questions anybody has. Jyoti, can you unmute please with everybody, 1 person at a time, if you have any questions?
Everybody's shocked.
I know. You can unmute yourself when you're asking a question.
I had one other thing I wanted to mention. So
Yeah.
you know how all of us are individual, but we're really not. Every Tuesday morning, we sit down together and we sit down with each of our individual breast cancer patients and we talk about them. So as the physicians sit down, we make a plan together. So it's not like each of us do things separately. We actually do come together as a multidisciplinary team. And that truly is very important, I feel. And Dr. Parikh is on there, Dr. Cheston, Dr. Keene, and we have several other physicians who join. So it's important to know that everybody talks to each other.
So each case is taken as individually, and then the treatment is also planned such a way.
We learn something every single Tuesday morning. We learn things.
Cool.
Absolutely. It's nice to have a comprehensive look at the patient, from every angle and put our collective heads together and get the best plan.
Yep.
We even look at the breast tissue that's been removed.
Yeah, pathology also, yes. Excellent. Look like everybody, I hope probably they're in a shock or they understood everything, and but any questions, you're welcome. Otherwise, we can just thank anybody. Has any questions or any comments or anything? Anybody? Very good. You have Vimala? I thought
I was wondering if some of the slides would be available to view later. Can you post them somewhere and just send a link, or?
We are on a YouTube, right, Jyotiji? So they may be there, correct? Can they view it later on?
The YouTube is going to, the link is going to stay live. So you can always refresh and watch this video again, and you can always invite your family and friends to watch as well.
Okay, so it'll be emailed to us?
It has been shared in the Mandir WhatsApp in the announcements, but if we will share it in future email from the Mandir as well.
I appreciate that. Thank you.
You're welcome.
Ready?
Under which title we can view at YouTube?
The link has been shared on Mangal Mandir announcements. So if you're a member of WhatsApp, please view over there. We'll also send it in the email and in the upcoming email.
Thank you very much.
You're welcome.
But if any of this listener is not on the Mangal Mandir WhatsApp and they want to watch the YouTube, is there any particular title they can watch?
I will post it in the chat here so that all the participants can copy before you exit this meeting.
Okay. All right. That will be great. Thank you. So it was very nicely done. And I just want to, anybody has any questions or anything to go by?
I just want to thank all the speaker panelists. They did a wonderful job in explaining every aspect of it.
Very good. Thank you, Ashok ji.
Pleasure.
Thank you.
Thank you very much.
And like to thank Jyoti. Jyoti, is so nice of you, doing this technological part. You know how good we were, and you helped us a lot. That's so nice. All three or four of us. And Stacey, Sally, and Teji, thank you so much for doing such an excellent job.
And thank you for organizing it.
Yeah, thank you.
So again, this is not to scare you. Just understand the facts, know about it, and hope nobody becomes a victim of this. But if it does, which we saw like a 1 in 8 probably may have this risk. But if it does happen, then there is a good outcome and hope also. So we are happy to help you anytime if you need, your family, friends, or anybody. Okay. Good.
Thank you very much.
Thank you very much.
Good night, everyone.
Really.
Night.
Right. Thank you so much.